Acute cholangitis, a comprehensive podcast Q&A, the ultimate guide for general surgery residents. Welcome to today's podcast on the management of acute cholangitis. Today, we're breaking down everything you need to know about this critical condition, using a structured question and answer format that's perfect for both learning and quick revision. Pause the video when you hear the word answer to attempt answering the question. Let's dive in. Pathophysiology and etiology question. What exactly is acute cholangitis? Answer. Acute cholangitis is a bacterial infection of the biliary tract that usually occurs due to biliary obstruction. Clinically, it's characterized by Charcot's triad, fever, jaundice, and right upper quadrant pain. Question. What are the main causes of biliary obstruction leading to cholangitis? Answer. The most common cause is cholelithiasis, which accounts for about 70% of cases. Other causes include benign strictures, tumors such as pancreatic cancer or cholangiocarcinoma, parasites like Ascaris, post-ERK strictures, and biliary stents. Question. I've heard about Reynolds pentad. What does it include? Answer. Reynolds pentad is Charcot's triad plus hypotension and altered mental status. Its presence indicates severe, toxic cholangitis. Question. What organisms are most often responsible for cholangitis? Answer. Gram-negative bacteria like E. coli, Klebsiella, and Enterobacter are most common. Gram-positive Enterococcus an. In chronic cases, anaerobes such as Bacteroides fragilis can also be culprits. Question. How does cholangitis lead to sepsis? Answer. Obstruction increases biliary pressure, which allows bacteria to translocate into hepatic veins and the systemic circulation, resulting in sepsis. Clinical presentation and diagnosis question. How reliable is Charcot's triad in diagnosing cholangitis? Answer. It has a sensitivity of about 50 to 70% but a specificity greater than 95%. However, only about 15% of patients present with all three features. Question. What laboratory findings suggest acute cholangitis? Answer. Expect to see leukocytosis, WBC, 10,000, elevated direct bilirubin, and an obstructive liver enzyme pattern with ALB. AST-ALT ratio. Question. What imaging modality should be used first? Answer. Right upper quadrant ultrasound is the initial test, as it can reveal ductal dilation, stones, or abscesses. Question. When is CT scanning indicated? Answer. If the ultrasound is inconclusive or if malignancy or abscess formation is suspected. Question. What about MRCP? Answer. MRCP is a non-invasive way to evaluate the biliary system, especially when ERCP is unavailable or too risky. Severity grading. Tokyo Guidelines 2018. Question. How is the severity of cholangitis graded? Answer. Mild. Grade 1. No organ dysfunction. Responds to antibiotics alone. Moderate. Grade 2. Features include white blood cell, 12,000. Fever, 39 degrees Celsius. Hyperbilirubinemia, 5 mg/dl. And elderly patients or those with comorbidities. Severe. Grade 3. Defined by organ dysfunction such as hypotension, creatinine, 2.0, INR, 1.5, or altered mental status. Question. What are the mortality rates for severe cholangitis? Answer. Without treatment, mortality ranges from 10% to 50%. Question. Which scoring systems are useful for predicting outcomes? Answer. The Apache -2 and SOFA scores are valuable, especially in ICU settings. Initial management question. What are the first steps in managing a patient with acute cholangitis? Answer. Airway protection for altered mental status. Supplemental oxygen if hypoxic. IV fluids and vasopressors for septic shock. Question. What antibiotics should be started empirically? Answer. Community-acquired infection, piperacillin tazobactam, or ceftriaxone plus metronidazole. Hospital-acquired, meropenem or cefepime plus metronidazole. Question. When should blood cultures be drawn? Answer. Prior to starting antibiotics, especially in unstable patients. Blood cultures are positive in 20 to 40% of cases. Question. What is the definitive treatment for biliary obstruction? Answer. Biliary decompression is essential, most commonly via ERCP, but percutaneous transhepatic cholangiogram or surgery may be needed in select cases. Question. When is urgent ERCP indicated? Answer. Within 24 hours for moderate to severe cases. Within 12 hours if Reynolds pentad is present. Definitive and advanced treatment. Question. How successful is ERCP in treating cholangitis? Answer. ERCP boasts a success rate greater than 90% for stone extraction and stent placement. Question. What are the main complications of ERCP? Answer. Pancreatitis, 5%, perforation, 1%, bleeding, and occasionally, incomplete drainage leading to persistent cholangitis. Question. When is percutaneous transhepatic cholangiogram indicated? Answer. When ERCP fails or is not possible due to altered anatomy. Question. What role does surgery play? Answer. Surgery is a last resort if other approaches are unavailable or for definitive management like cholecystectomy and T-tube placement. Question. When should cholecystectomy be performed after an attack of cholangitis? Answer. Within 2 weeks, especially if gallstones caused the episode. Complications. Question. Can you walk us through some complications of cholangitis? Answer. Emphysematous cholangitis, gas-forming infection requiring emergency intervention, liver abscess, occurs in 1 to 2% of cases, needs percutaneous drainage and extended antibiotics. Biliary venous fistula, rare, presents with gastrointestinal bleeding, biliary colic, and jaundice, post-ERC pancreatitis, managed with NPO, IV fluids, and pain control, sclerosing cholangitis, chronic strictures, often autoimmune, mimic infectious cholangitis, special populations and scenarios. Question. How is cholangitis managed in pregnancy? Answer. ERCP with fetal shielding is the treatment of choice. Use radiation-free MRCP for diagnosis when possible. Question. What about patients with cirrhosis? Answer. Management is more challenging due to increased mortality. Early ERCP, cautious fluid use, and possible albumin infusion are recommended. Question. Any recommendations for immunocompromised patients? Answer. Broader spectrum antibiotics and sometimes antifungal coverage are needed. Technical and surgical considerations. Question. When are metal versus plastic stents preferred? Answer. Use metal stents for malignant obstruction and plastic stents for benign or temporary drainage. Question. How is cholangitis managed post-liver transplant? Answer. Urgent ERCP with stenting, along with adjustment of immunosuppressive therapy. Question. What are some emerging concepts and rare scenarios in cholangitis management? Answer. Common nasobiliary drainage for temporary decompression. Merisi syndrome often requires surgery. Brush cytology and cholangioscopy for tissue diagnosis and direct visualization of strictures or stones. Liver transplant consideration for end-stage disease. Question. To close, what's the most common cause of death in cholangitis? Answer. Septic shock with multi-organ failure remains the leading cause. Thank you for joining us for this comprehensive Q&A walkthrough of acute cholangitis. For more in-depth discussions, stay tuned to our next episode of the Everything Surgery podcast. Remember to like, share and subscribe.